me if I get any of this wrong. Associate Professor at Georgetown and Director of Palliative Care at Washington Hospital Center. Also serves as the Fellowship Director. No, okay. But when we have the opportunity to get together, which we do twice a year, we like to invite one of our investigators and our investigative leaders to kind of describe how they're spending their time and kind of inform all of us. Gives us the opportunity to learn about what's going on in our system, and I think hopefully helps us when we. So thank you for.
Spending my time. It's really nice to have the time to share some of this thing. Specific. I could just give as a couple of years. The system providing palliative hospitals. Last year, the system we provided over 10,000 patients. The system, so very busy clinic. Added in the different hospitals, which take a couple of years. Few of us with a lot of support from have been interested in exploring. Interesting. Some of the centers around the country that have bus palliative structures like University of Colorado. And then, yes, as a broad sweep, we're building our sense of our strategic goal. Sort of fall, sort of three research. One is conducting randomized trials of different palliative interventions for states, but that, and then I'll focus on that today. The things.
Use control instance. And I'll point out as we're answering to slide chat online.
Yeah.
Our defense officer. Two that are listening in.
Oh, great. Okay, great. Well, I mumble, so if you can't hear. So what I'm going to share today, I asked, for example, symptom science. For pain. Example of the search. Creative therapy is interesting. But I've really been much to virtual rapidly. It seems to have a potential to sort of farm parts of our brain that we might not. So I have been particularly talking a little bit about sort of technology and
It sounds really good. Oh, we're not sharing. Hold on. Yeah, we are.
I'm gonna just see.
Yeah, go ahead.
I requested to someone.
That's not coming up here. Okay.
Yeah, mouse over. Allow.
Right. You request again?
Yeah, you just say, but I can't even get to that.
Okay, why do I?
Yeah.
It's like a double screen.
Yeah.
So
Then we saw you up there front.
Did you? There we go. Right there.
So in
Here, actually.
palliative care, I think most people really was going. So it's a relatively young field. I think what really started out as sort of changes in terminology. So it's on end of care and started to use more and more. And this, so really kind of mess around process trajectory. And in area of pain, of course, that's sort of like a cornerstone symptom for us. And this related pain certainly states there percentage of sample population adults living or have some degree of disease itself or just treatment. States that cancer, chronic cancer pain. It's also a problem in a lot of other non-states. I think that's all the and all the, but we have disease, for example, associated with there's a lot of room to be thinking develop better ways. Settings, and of course, not even to get into chronic back pain or neuralgia, neuropathy, so much data, such high prevalence. Individuals entire community. So next slide. I started to get really interested in this in virtual reality when some of the early virtual reality some as far back as virtual reality technology starting to some investigators in Washington were interested in really changing so there's I've been interested in so has the challenges are for a while. But it's used to work at National Institutes. Started that around. A lot more challenging. Washington Hospital. That is. Massage or access or some of that is also some well documented things with populations that have different awareness as or as a culture about creative therapy. So, this is some data. Which is really for, I've been studying sort of interested in terms of traditional approaches to massage therapy. I'm for sure people therapy insurances. So I think kind of putting all this together, and this actually is a lot, some degree with massage trials that we've think of to bring. Okay, so so I started to say that the University of Washington researchers started looking at a small number. They started to do small experiments where patients who were set up these things or apparatus and engage them in sort of to see whether some level of function and absorption would change the experience. Burns ones, you know. And over time, what they found in small studies was telling that patients were able to self-reported also immunotherapy. So something interesting to sort of think about from time that phase of looking at procedures, really procedures, pediatric procedures. They were sort of short into the try to think of some of the way experience that might be. And what they really found is that across different demographic groups, that it seemed to be really technology got better and better, continues to get better. Tolerating. But a few years ago, at least, my interest or focus on it was really maybe 5 years ago, really nothing like cancer pain syndromes at all, totally different. So I started to get kind of interested in this that I center. Spent a lot of time heart failure. So a lot of the complex just opioid. try to manage. Frustrating to them, frustrating to patients, frustrating to our. Frustrating to us. This is an example. This is the game tool. One of left upper extremity on the right. Game was literally just sort of floating. Straightforward stuff. So in the cardiac disease sphere, Ben and I got a small grant. Washington Hospital Center, who were moderate to severe. The indication really procedure pain. Adults, they study they had to have. Excluded people like all of these. Challenges, so if they can't sort of wear a headset, headset. Technology, the history of nausea, vomiting, sickness that we could talk about side effects of this a little bit. As you can see now, this is not the first kind of device that we use, but these are the sort of over the actually the company. They all kind of look like that. It's just sort of off the shelf. This is kind of what the technology looks like we're talking about. I did want to share is that these are two hand controllers. Using the experience, I'll talk about is the term experiences. Technology is changing. To be able to use just changing these same people have some experience. Abilities and some actually hospital. In any case, back to the study, patients, we randomize them 10 minutes of virtual reality. Sort of state. Experience. 10 minutes of the equivalent that we could and randomize them to one. And then we collected some measures before and after, mostly thinking about self-reported. Other measures as well. Class and quality. And then we went back actually a day after measures of intervention. Again, our primary back the next day and this is the forest that's around. I don't even think I'm gonna watch sort of move here's kind of this is when we start. I don't know what I really expected to find. I thought it was sort of, to be honest, I think in palliative. We found the difference from intervention change significantly. Action. This is next day. Again, as therapy stuff. That was kind of interesting.
This was after a single intervention.
After a single intervention. Published that. And then we started to think about what's this sort of residual in. So. Thing and started to different populations here. So keep going. Did this again with a grant from the American Cancer Society. Similar kind of study in patients with cancer pain, moderate to severe baseline. Similarly, and this time we also added an exploratory analysis and preference. Started getting develop so very similar study, similar outcome. And this is, we used a different experience called Nature Track. So this was, again, a little choice for the participants that sure they could be escape, they get 6 or 7 choices that they have. The two groups were very similar. Baseline, when we started to really pay portions of medicine. Of folks at their baseline get so essentially and we found the same thing. Distraction therapies work. Virtual reality works. Virtual reality. Self-reported.
Let's keep going. Our other last number, just gonna grab it. Sure.
Thank you.
I'm just thinking that I'm driving a traffic.
So you can see, this is just, the pain scores from baseline, post intervention. And it's sort of like perpetuating. Interesting. I got to present this at working. Sort of drug. So it's exciting to continue to. And then the qualitative data that we're starting to work on is kind of some of our business health technology. Very interesting. Really interested in that. All of this is kind of based on distraction therapy, different environment, and someplace else. And so that's really important. But what might be here even more exercises. Survivors. Experiences and things out of the arm. Since people want choice. How do we technologies that how do we study different things? And the last study that I'll mention is one that we're wrapping up right. Yeah, but this is where we were taking that. It's when you session of VR start to think about virtual. So this is a pilot study that we're finishing up with patients with pain. The hospital center again. Just taking this pilot group and baseline dose escalation. Patients with start with baseline measure, happen cognition. Given today. Day or 5 times a day procedure. And I'm really interested in kind of our brains. Better control. VR research, as I mentioned, has been just interesting virtual reality. So again, for that initial interest of mine in exploring ways to get success. People are not interested to. So just to kind of wrap it up, this was getting kind of interesting to me, and this is a direction that I'm working. I don't know if anyone. I was not. Sort of ear infrared spectroscopy of a really tight skull cap on functional MRI, but it's not. Trade with centimeters measurements of what's going on. Parts of what's happening using technology can't otherwise. It was an interesting study. Healthy volunteers, deaf nerds attached to them had actually different virtual reality. And then an example. Trying to get interesting to me. Short of it, this particular study of health self-reported and through physically engaging the VR response better than medications or pain. So we start to add some science to like what kind of activities could we be. So that's something. Last thing I'll mention is Hasn't been done yet in a clinic setting, but again, I'm interested in how virtual reality pathway or a gateway. Do the study of that's the health. Ways to get at that stress through mindfulness and education. Stress reduction program, traditional mind stress reduction program, but today you sort of follow the same program except embedded to people who less stress than the are people likely to. We're starting to look at chronic.
I have one question. As,
Sure.
and I've tried VR for other reasons. What? I mean, are y'all looking at other ways of doing this without but with like without the motion or some way where it's not? Because I see where the benefit is, and I mean, I see the things like you have up there besides the cancer treatment, which is anxiety, which is a huge thing, and probably some of the other psychological things that we see. What do you guys have, or what's kind of on the frontier for people? Like this?
Yeah, I'm glad you're asking that. Thank you. I think we've been really lucky so far in the studies that we this offensive. I think the numbers in like bigger studies, like maybe sort of some kind of like sort of a Lego or. I think to answer your question, one solution is the technology gets better. Part of it is so lower. What you're doing also matter. I like VR and it makes I use virtual reality. So some of it depends. I think part of what experiences are more tolerable. Just
Right.
better. So I think that a combination of the technology experience and some of the, not just the VR itself getting better, but some of the actual software can be sort of technical. I think that's coming. Otherwise, it's just.
Yeah, and I mean, you're talking about the cancer therapy, which I think is wonderful. And I'm thinking of things like, I'm wellness with my residents. I try to do well. That's because I do with my residents, but anyways, and I'm thinking, it would be nice if people could come up with ways where people who do have pretty severe motion sickness, when they put on a VR, like set, whatever you want to call it, I mean, it sounds like what you're saying is that maybe industry is doing that, but I think it's really important because I think if, when I hear you talk about this concept, that concept can be spread out over different areas of medicine and in behavioral science and in psychology, psychiatry, right?
Sure.
But I have to say, for most people, myself included, it's a limiting factor for me to put those on because almost as soon as I do, because I've done it, I am so motion sick and then I have to go take medicine. So, and I don't think I'm like an N of one. I mean, I'm not like I'm not at that end of the scale, but I'm not at this end either. And I think if you're at the middle, even a little above middle, that's probably a lot of people are there and it'd probably be worthwhile to. I mean, I'm not saying it directly to you, but it'd be worthwhile for them to be able to come up with that because I'd get on VR to do meditation or relaxation but right now I can't do it. I've tried.
Yeah, no, that's well taken. And it's definitely something that we're
Yeah,
in order to reach patient populations of
Yeah.
interested in that it's to sort of. Sure. Another thing that is a little bit newer in this space that we're also exploring is in reality, which might solve some of that.
Mhm.
It's not as immersive, obviously, because it's but to figure out are there that could be that might be a strategy that regardless of the nausea, motion sickness, all of that stuff, that just might be something that some people just
Yeah.
don't want to sort of disappear.
Yeah.
I think there's a lot of directions that this will certainly going to go in.
Good.
And we'll just
thanks for answering the question.
yeah, sure.
This is an off-the-shelf product, so anyone can get it. With the evidence that's out there now and the risk profile, do you recommend this to your patients ever outside of the study? Say, hey, you might want to try getting an Oculus.
No, I mean, I think that's a good question. I feel like all this work that we're doing is so new that I haven't, like, I need to do that yet. Although in the hospital, I mean, I'll just say like from anecdotal, if there's a practitioner was working ago who was actually having some wound care. Said, hey, I would definitely recommend, not enough to say like, you need to go buy it, but certainly enough to get interested in. I'll say it, there's there's like a small group of participants that are really interested in this and keep coming to studies. I think there's a one. Yeah.
You mentioned like if this were a drug, people would be super enthusiastic and interested and maybe like subtext is a lot of funding. And any interest from the VR headset makers in kind of supporting research into this and that they might, get insurance to cover someone's, VR headset at some point in the future?
Yeah, I mean, that pathway is definitely not my, I know that all businesses are interested in that. There's one FDA approved approved experience or something. Actually, you do shots down, so it's flexibility. Choices, but there's something out there. So there's a pathway, and the FDA, I think, has been trying to, like, since I started all this 5 years ago, there's nothing available. There's this new. So maybe the FDA is starting to think about how that will assume that will remove it. Should probably.
I have a couple questions. One thing that strikes me is hospital center is so chaotic. Do you feel like you may be seeing a exaggerated benefit because of the environment in which you practice?
That's a great question. I don't think so yet, because I think that other developing studies at different places. I don't think that we would have gotten to this point. So there's a long track record. It's certainly possible. That's part of.
Well, do you go over to Georgetown or is there somebody, I'm sorry, I missed that part. Do you have somebody over at Georgetown? Because it would be, I mean, and I'm thinking about what Manish said, which is, how do you balance that? If it's really chaotic, does the chaos have some effect with the VR, vice versa? But Georgetown is so quiet and it's not chaotic and it's very, I'm over there a little bit. And yeah, I know, right? It's very quiet when I'm over there. It's so weird. I can't tell you. Yeah, oh, it's quiet. So all I'm saying is that would be a great, like, juxtaposition of the two, because then you'd have kind of that chill place and then the crazy place,
Yeah.
which I love, by the way. And then you could kind of compare those two. I don't know. I mean, I think that'd be kind of neat.
Yeah. But I mean, certainly, yes, all of these things.
Have you noticed any trends in who chooses to participate and who declines participation?
I haven't, yeah, I don't know, this is what was on. It's mine, that, and I would, so too, like, this position must be younger positions, interested in technology, certain kind of graphics and like graphics. I think in both of our like overall in our studies, across the board, participants is like 7 years old. So people are really interested to try it. And feel like I could say a priori, like this person's really. Some of it is sort of anecdotally, I think when we finish that quality from that study, that will help us understand. I feel like there are particular moments when participants become sort of attached to the experience that they have. I can think of said 20 years. That was my favorite. But I think being able to kind of tailor the experience to the person or allow the person the flexibility to become.
My last question is, I'm not sure that this is answerable, but and kind of specifically wearing my IRB hat and thinking about our core principles and the principle of justice. One of the things that we've historically seen and we worry about is testing a product or an intervention amongst a population that can't afford the intervention once it's approved. Do you see that at all, or do you worry about that at all with this? And that is your patient population underserved and unable to afford the product?
Yeah, a little bit. I think about that both. So the first two studies we did were inpatient studies, and if this were something that kind of worked in a hospital setting, that'd be something for the hospital to kind of take up and have. Outpatient study that we're finishing up, we actually included that in the fund. So if you participate, which I thought was some people could do anything. I think in the long run, is that the cost of one of these off the shelf today would be the prices will continue down, et cetera, et cetera. But that's certainly something that is worth. Certainly something that was nice, at least in our outpatient study, to try building the budget so that we try to mitigate that. That is something that's.
Well, one question, I guess, as an IRB board member, I was fortunate enough late last year to be able to sit in on a couple of virtual sessions at Primer, which is the big annual IRB type conference that specifically addressed devices and treatment at home and all that. And it seemed like there was a preoccupation with absence of tech support for patients and difficulties of, difficulties in providing enough support for patients for these things, for this remote treatment to be feasible at home. Which leads me to ask, just how much difficulty do you have in that regard with getting individuals trained and with following up on tech support requests? Because I'll tell you, I'd love to hear that it's not nearly as big a problem as the education that I've received in that area, because it would really alter how I view things.
Yeah, I think that, again, like the work that we've done so far is. I think that, like getting outside of my expertise, when I think about cost of a device, the cost of a smartphone, the cost of other technologies that many people are able to afford or able to afford, the way that healthcare is moving into that direction. I guess my own sort of small experience in that space and probably much more about that bigger question than I do, for sure. Yes, is that again, like for products that are being built, public and we're all collectively, or the people who are making this, are going to have to think about make sure that everybody can have access to them. And the studies that we did, we really just had a study coordinator who kind of get the device going, sort of a cheat sheet work, sure what to do. So this is just important to figure out. It's straightforward. And again, technologies that we've been thinking about are all sort of continuing on, so it's not relying on software on the headsets of people.
So I guess what I'm getting at, and I didn't frame it well, is just how often did your phone ring or your coordinator's phone ring for VR headset tech support that wasn't in the workbook?
Yeah, a handful of times. The last one with the pilot was 33 patients. I think one person had to exchange the device. It just didn't work. And then
Thank you.
maybe they're not, telling us everything, but those things.
But that's reassuring.
Well, I think the other interesting thing about, kind of what Les asked, but as I'm sitting here listening to you all is, people in general have become more savvy with electronic gadgets, right? So my 55-year-old patients, for example, are texting and doing things that if you'd asked them even 10 years ago, they'd look at you like you were crazy and had 3 heads. And now they do it naturally. And they learn that, and nobody sat down with them and taught them how to learn it. They did it on their own, and they had their bobbles, they had their ups and downs, but at the end of the day, they can use the phone, they can text people, and they can do basic, probably email and stuff, right? So I don't see where that would be any different with your patient population or our patient population in this setting, because they'll figure it out. They'll have their bobbles, but at the end of the day, they'll be like this phone. That's my personal feeling.
That's my guess. In both of our inpatient studies, the guided imagery tablet was easier to use than, but both groups were equally satisfied. So I think
Yeah.
people out, and that's a lot of the way our society goes. It's just maybe we should pay attention to that.
No, I totally agree. I think it's naturally, you're gonna see it naturally more efficacious in their learning and their ability to do it than we would imagine, right?
Yeah.
Because sometimes we don't give those folks enough credit, because a lot of them are a little bit older. They do it just fine. Like I watch them do it in my office all the time. It's amazing. Some of them know how to use it better than I do, I think. Just the phone. So I don't think the leap to the VR would be that much different.
No, so I felt like a priori,
Yeah.
I can't quite tell.
Yeah.
Say like that person will really do it.
That's right. That's why I figured, yeah, that makes sense.
And let me just add this, the food I think is out. Are you sticking around?
No, I gotta go.
You gotta go, unless you should ask you a question.
Well, this is totally out of my wheelhouse, but at least based on the exposure that I had at Primer, and maybe the studies are there. One other small little piece to include in one of your next grants are some meaningful data on how trouble-free the devices are to try to dispel what
Myth.
seems to be this myth or notion that there's a heavy patient load in utilizing these devices.
Yeah, thanks. The one I'm hitting submit on next week, the proposal I'm hitting submit on, someone from the human factors.
Thanks.
Thank you for joining us. That was great.
Thanks a lot.
That's very informative.
Appreciate it.
Here, you can't stick around for a little bit? Okay, thanks. Thanks.
Yeah. Yeah, we'll set up a call. We'll maybe drag Wendy in to discuss with us too. Yeah, of course. Yeah, absolutely.
Yeah.
We'll get it done.